Good morning, good afternoon, hello, and welcome to CDP Presents, our monthly webinar series. We are happy to have you and join us today. And if you've joined us before, as always, welcome back. I'm Dr. Jenna Ermold, Assistant Director of Online Training, Technology, and Telehealth, and part of the CDP Presents team. And I'm coming at you from snowy Colorado. I saw another snowy Colorado person joined us as well. I'm a little jealous of Kristen in Hawaii right now. We've got someone from the UK, so I always am so excited to see where we're coming from nationally and internationally. We're delighted that you were able to join us today. Our standard disclaimer, this project is sponsored by the Uniformed Services University. However, the information or content and conclusions do not necessarily represent the official position or policy of, nor should any official endorsement be inferred on part of USU, the Department of Defense, or the US government. We are really excited to release the 2023 lineup for CDP Presents. So here is your official save the date. Block those calendars and you can head on over to the training page on CDP's website, which is listed on the slide, to register now for any of these upcoming fabulous webinars. We are really looking forward to a fantastic season. As always, here's a snapshot of some of the other upcoming trainings that CDP is offering in the next few months, which is also found under the training tab on CDP's website. So feel free to check those out if you're looking for some training on couples, and there's prolonged exposure, lots of good things coming up. We wanted to highlight again this month a free, fantastic training opportunity. Did I say free? Free. That's being offered 3 times this year in collaboration with our colleagues at the National Center for PTSD, training on assessment of PTSD and suicide risk management in veterans. I'm sorry, that was funded by the PTSD consultation program at the VA's National Center for PTSD, and also collaborating with VA's suicide risk management consultation program and CDP. This is a great 2-day workshop that aims to introduce participants to military culture, help you develop some skills in assessment for 2 important clinical issues, PTSD and suicide risk. For more information and to begin the application process, feel free to visit the website at the bottom or scan that QR code. Just a note, this is only for licensed behavioral health providers who regularly treat U.S. veterans or who intend to treat U.S. veterans in the community. This is not for behavioral health care providers currently working in VA or DoD settings. There are still some slots for all these upcoming trainings, so please do take advantage of this great opportunity. There are 14 credits through APA, NASW, and ACE, which is awesome. And another Colorado, excellent. Says the QR code has been deactivated. All right, Brittany, I'll look into that. In the meantime, if you maybe, Micah, during the training, you can put in the link for that. That would be fabulous, or it's definitely on your slides if you need it, but I'll look into that QR code. Sorry about that. Hopefully this one's not deactivated. Also want to remind folks that our 2023 Evidence-Based Psychotherapy Conference, Answering the Call with Focus, Flexibility, and Fidelity, Implementing EBPs in the Wake of Public Health Crises, is going to take place on May 11th. Again, a fantastic lineup, including our keynote speaker, Dr. George Bonanno. There are pre-meeting EBP workshops that are listed on the slide there. And but it's ACT, CBT for chronic pain, and motivational interviewing. This is a screaming deal. This isn't on the slide, but just so you know, it's $45 for both the PMI workshop and conference. So the 3 days, 2 days of EBP workshop and conference is $45, and the conference only is $20. So it's kind of want to emphasize that because there's some really great speakers and presentations, and it's very rare to find conferences for $20 these days that are including credit. So hopefully that QR code is working. If not, I'll fix that one too, or you can go to the link at the bottom of the slide for more information. If we missed you last month, never fear, we've got you covered. You can find the recording on our archived webinars page. If you attended the webinar and liked it, feel free to pass it on and share it with colleagues. It was a fantastic presentation for sure on ACT, psychological flexibility, and ACT in chronic pain theory and application. Lots of you know that CDP wrapped its second season of our podcast, Practical for Your Practice, and we launched season 3 in January, which we're very excited about. This bi-weekly podcast features stories, ideas, support, and actionable intel to empower providers to keep working toward implementing EBPs with fidelity and effectiveness. If you missed seasons 1 and 2, they're also available for binge listening. And we currently are not offering CE credit from archive trainings, unfortunately, but you can at least kind of absorb the content, which is fabulous. As always, I'm just going to walk you through a few things that we can enhance your experience in our webinar. As always, we recommend that you close programs to enhance that connection. If you entered in full screen, you may want to click on the screen and hit escape. It makes using some of the features a little bit easier. If you're having any difficulties viewing or hearing materials, it's probably due to a poor connection. Right now is a great time to check the volume on your computer or device. Many participants find it's very helpful to use a headphones or a headset. I've seen a lot of you have already found the chat feature, which is great. This is how we do a lot of our communication. If you can make sure that you select everyone, if you set that little blue drop down, that way everyone can see your great comments, questions, and it's not just coming to the host and panelists. Feel free to put your questions in here, respond to things that our speakers are saying, and if you have any technical difficulties today, you can throw that in the chat, and someone from our support team will reach out to you. This webinar, as always, is being recorded and will be posted to the CDP's website along with any additional materials and references. Handouts for today can be found in your CE21 account, and we can also post a link if anybody's having difficulty finding that. Finally, at the end of the webinar, our project manager, Mr. Micah Norgard, will provide information and instructions on how to obtain your CEs. In order to obtain CE credit, you must attend the entire webinar and complete the survey in CE21. As always, we are offering American Psychological Association CE credits, which are acceptable to most state licensing boards for different mental health disciplines. Just check those requirements for your state and retain documentation associated with the training. And thank you, Bree. Just put in the link to get to the handouts if you were having trouble in your account. And now, without further ado, I am thrilled to introduce some of our fantastic colleagues at the Uniformed Services University. First, we have Dr. Marian Tanofsky-Kraft, who is a professor in the departments of medical and clinical psychology and medicine at the Uniformed Services University. She is a research director for the Military Cardiovascular Outcomes Research Program and research collaborator in the section on growth and obesity at the Eunice Kennedy Shriver National Institute of Child Health and Human Development, NIH. Her research program involves the intersection of obesity and eating disorders and addresses questions about risks, protective factors, maintenance, consequences, and prevention. She is on the Executive Council and a Fellow of the Obesity Society, Fellow and past board member of the Academy for Eating Disorders, and is a past president and board member of the Eating Disorders Research Society. She is joined today by her two fabulous colleagues, Dr. Natasha Chevet, who is an associate professor in the Department of Medical and Clinical Psychology at USU, as well as a research collaborator in the section on growth and obesity at the Eunice Kennedy Shriver National Institute of Child Health and Human Development, NIH. Dr. Chevet has over 16 years of experience in research and treatment of high body weight and disordered eating spanning from childhood to late adulthood. And last but not least, we have Dr. Jason Lavender, who is also an associate professor in the Department of Medicine at USU and deputy director of research for the Military Cardiovascular Outcomes Research Program with the Metis Foundation. He has 15 plus years of experience in eating disorders in the eating disorders field with a research focus on risk maintenance factors and the unique manifestations and assessment of disordered eating among males. Doctors Tanofsky-Kraft, Lavender, and Chevet have no financial interest to disclose. And now it is my pleasure to turn things over to the team presenting today. So thank you so much.
Great. Thank you so much, Dr. Ermold. I really appreciate the introduction. So as Dr. Ermold mentioned, it will be 3 of us presenting today. So we will be doing some tag teaming to get through all of our content. So please forgive us if there's any clunkiness as we transition from speaker to speaker. So I wanted to just say good morning, good afternoon, good evening, depending on where you all are joining from. We're delighted to see such a large group of people in attendance today, and whether this is an area of particular clinical interest or research interest, or whether you're just here for the free CE credits, we are delighted to have you and are hoping that this will be a really engaging and informative presentation. So we welcome all of your questions. We've got a lot of content that we are hoping to get through, but we certainly want to take time towards the end to answer any questions that you all have. So keep them coming in the chat, and we will try to periodically monitor those and make sure that we're addressing any of your questions as we go. Great. So to go ahead and get started, I always like to provide an outline just so we all are on the same page and can know what to expect. So we'll be starting today's presentation with an overview of the most common, or sort of the main eating disorders that you may be coming across in your clinical practice. We'll then provide an overview of assessment techniques and how to assess for and diagnose eating disorders. We'll then provide an overview of some of the most frequently used evidence-based treatments. Of course, this is not going to be an exhaustive list given the time constraints, but we will touch on some of the most common and well-supported treatments. And lastly, we will end with some military relevant considerations for both active duty as well as veterans and dependents. And lastly, we will end with some clinical recommendations that hopefully you all can take with you and integrate into your clinical practices. So before I really get started, I just wanted to begin on a note about language. And as I think many of us in the audience know, language is really critical in how we conceptualize some of these disorders. So throughout this presentation, we will be using person-centered language. And what I mean by person-centered language is, instead of referring to the anorexic patient, the bulimic, or the obese person, what person-centered language effectively does is it flips it around so that we start with the person and then with the condition. So using person-centered language, we would refer to the patient with anorexia nervosa, the person with bulimia nervosa, or the person with obesity, or better yet, high body weight. And the discrepancy or the difference between obesity and high body weight, that is a conversation for a whole other talk, but we just want to be mindful of the language that we're using throughout. And we really do encourage you to begin using this person-centered language if you are not already using it. So with that being said, I wanted to just really provide a very broad overview of what is an eating disorder. So at its core, an eating disorder is a persistent disturbance of eating behavior or behavior that is intended to control one's weight, which significantly impairs one's physical health and or psychosocial functioning. And this disturbance should not be secondary to any other recognized general medical disorder or any other psychiatric disorder. So we will go through and identify some of the most common eating disorders, beginning with anorexia nervosa. So anorexia nervosa refers to the restriction of energy intake, or what one is eating, relative to requirements, which subsequently result in significantly low body weight given one's age, one's sex assigned at birth, one stage of development, and so on. Anorexia nervosa is also characterized by an intense fear of gaining weight or becoming, quote, fat, or persistent behavior that interferes with weight gain or weight maintenance. Individuals with anorexia nervosa also experience a disturbance in their subjective experience of weight or shape. Their self-worth is unduly influenced by weight or shape, such that weight or shape are really primary in how they conceptualize themselves or their self-worth or value, or a persistent lack of recognition of the seriousness of low body weight. Anorexia nervosa is further divided into 2 subtypes. So those are the binge eating and purging subtype and the restricting subtype. So briefly, the binge eating and purging subtype refers to individuals who regularly engage in either binge eating or purging behaviors, whereas the restricting subtype, individuals do not regularly engage in either binge eating or purging. And importantly, restriction is really the sort of common thread across both of these subtypes. So the subtypes really just further differentiate based on the presence or absence of binge eating or purging. Some common comorbid psychopathology associated with anorexia nervosa include major depressive disorder, anxiety disorders, substance use disorders, which are more commonly seen with individuals presenting with that binge purge subtype. Obsessive compulsive disorder, as well as obsessive compulsive personality disorder, as well as other features that include competitiveness or a sense of perfectionism. Individuals for whom anxiety is perceived as functional for the achievement of some of their valued goals. So that anxiety is sort of adaptive in obtaining these goals. And interestingly, continued starvation may actually have an anxiolytic effect on the body, meaning it actually serves to reduce anxiety. Therefore, it really reinforces some of those behaviors that we see. Some of the medical consequences associated with anorexia nervosa include amenorrhea, or missing one or more period or menstrual cycle, constipation and GI distress, cold intolerance, the development of lanugo, which is sort of this soft downy hair that's often seen on infants and newborns that develops across the body. Anemia, or a low red blood cell count, that contributes to fatigue and feeling weak, hypotension or low blood pressure, impaired renal function, cardiac arrhythmia, or an irregular heartbeat, and that is actually one of the primary contributors to the lethality of anorexia nervosa. Osteopenia or osteoporosis, so bone loss or bone mineral density that is below what we would expect given a person's age, as well as death, and that includes by suicide. Importantly, anorexia nervosa actually has one of the highest mortality rates of any psychiatric disorder. And it really, as you can see, affects nearly every organ system in the body. The course of anorexia nervosa is highly variable. So for some, they might experience recovery after a single episode, whereas others might experience long-term fluctuating patterns of weight regain and relapse over time. And still others might experience a chronically deteriorating course that increases in severity. Crossover between AN and other eating disorders is very common. So both within the subtypes of anorexia nervosa that I've mentioned, as well as with the other eating disorders. So specifically about 1 in 3 individuals with anorexia nervosa will cross over and go on to develop a bulimia nervosa. And about 1 in 4 individuals with bulimia nervosa will cross over into a diagnosis of anorexia nervosa over time. So I will go ahead and hand it over to Dr. Chudnovsky-Kraft to provide information on some of the other eating disorders.
Thank you so much, Dr. Chevet. So yes, I will move on to bulimia nervosa, which many of you probably already heard about, but specifically bulimia nervosa in the DSM is defined as binge eating at least 1 time a week for 3 months, which is responded to by inappropriate compensatory behavior, specifically used to prevent weight gain, also at least one time a week for the past 3 months. And I'm going to give some examples shortly of different types of inappropriate compensatory behaviors. Individuals with bulimia nervosa have self-evaluation that is unduly influenced by their body shape and weight. It's sort of their everything, their self-importance. It's how they value themselves, is how their body looks and how much they weigh. If you see someone with both anorexia nervosa and bulimia nervosa, you would assign them anorexia nervosa as a diagnosis with potentially some specifiers. So what is the definition of a binge eating episode? And I'd like to be really clear on this. A binge eating episode is characterized by both of the following. So eating in a discrete period of time, an amount of food that is definitely larger than most people would eat during a similar period of time under similar circumstances. That's how it reads in the DSM now. As you can see, that's a little subjective, which is why I often think this second piece of a binge episode is possibly the more salient feature, and that's a sense of loss of control over eating during the episode. So someone doesn't just eat a large amount of food, or what they perceive as a large amount of food, but they must have that sense of loss of control for it to qualify to be a binge eating episode. So here's a sample of a binge eating episode of a patient who I actually saw years ago. And this person had eaten within a 30-minute period, a 9-inch Sara Lee cheesecake, a pint of low-fat frozen yogurt, the full pint, and 20 oatmeal cookies. And this was after dinner, late in the evening. And this individual experienced the feeling that they just could not stop while eating. They were out of control. And then the binge episode, to qualify for bulimia nervosa, is followed by some form of compensatory behavior. In other words, to make up for the binge episode. The most common one we hear about, we see in the media and movies, is often self-induced vomiting, which is a form of purging. Other forms which are often the case that we'll hear are laxatives, misuse of laxatives, diuretics, enemas, any other kind of medication that is designed to purge, to get rid of the binge episode. Some people will fast. Excessive exercise. And again, that's something you have to investigate. Is this a person who runs 5 miles every day, and then the day after a binge, they're running, 10 miles, 20 miles? So it's really in response to the binge episode. Among individuals with type 1 diabetes, we will often hear about insulin omission in order to avoid weight gain. So there's a number of common comorbid psychological disorders with bulimia nervosa, as is the case with all psychological disorders. Of course, mood disorders, anxiety. We see a lot of anxiety associated with eating disorders. Post-traumatic stress disorder, which is highly relevant, of course, to individuals in the military. Substance abuse disorders, personality disorders, in particular, borderline personality disorder has been cited to be highly comorbid with bulimia nervosa, as well as a number of self-harming behaviors. And I'm not just speaking to suicidal behavior, but also often we'll hear about people cutting, even if it's in a non-suicidal framework. So there are a number of physical signs. Often you'll see sores around the mouth, and that could be from the self-induced vomiting, dryness, calluses on the scars in the knuckles. That's called Russell's sign, and that can be from putting one's hand down their mouth to try to get the vomit to come out. Damage to tooth enamel. So the sores on the mouth and the damaged tooth enamel are interestingly often identified by the dentist. Many times we'll hear from someone will come in and say, my dentist referred me. And dry, flaky skin. And similar to anorexia nervosa, individuals with, particularly with chronic bulimia nervosa, will often say they're very cold. So there are a number of medical consequences, electrolyte imbalances, gastrointestinal issues. We see menstrual irregularities, postural hypotension. Very often you'll hear about esophageal tears and ruptures. When someone is vomiting quite a bit, that's a real concern and it's very dangerous. Arrhythmias, dental problems. And the list goes on. Parotid swelling, which is, you may have heard of before, the chipmunk cheeks, where people's cheeks swell up from self-induced vomiting, as well as chronic renal failure. So the course typically begins in adolescence or early adulthood. Interestingly, and not the case necessarily for other eating disorders, but the binge eating usually occurs during or after someone engages in inappropriate dieting or severe restriction. So you'll often hear that when someone comes in with bulimia nervosa. And for many people, bulimia nervosa will last for several years. So it can be a persistent disease. So turning to binge eating disorder. Now, binge eating disorder was added to the DSM in 2013, and we are just learning so much more about it over the years. Basically, binge eating disorder is engaging in at least one binge episode, similar to that sample binge episode I shared with you, at least one time a week for 3 months. And the episodes need to be associated with at least 3 or more of the following correlates. So, for example, eating much more rapidly than normal, eating until uncomfortably full, consuming large amounts when one's not physically hungry, eating alone because of embarrassment about how much one is eating. Furthermore, the individual feels disgusted with oneself, depressed, or very guilty after the eating episodes. They also have marked distress regarding the binge eating. It's very upsetting to them. However, they do not engage in regular compensatory behaviors. And I emphasize regular, because occasionally I will see someone with binge eating disorder who tried to self-induce vomit or tried to overexercise once or twice, but not at least one time a week for 3 months following the episodes. So what's the course? Well, the research generally is mixed. There are some people who amazingly remit or spontaneously. There are also many who persist over or quite some time, will have many, many, many years, and they don't get better without treatment. Similar to what Dr. Chevet talked about in terms of the crossover between anorexia and bulimia nervosa, we often see a lot of crossover between binge eating disorder and bulimia nervosa. And this has been supported through many years of research. Many people, by the time they come in and see you, will have indicated a long history of binge eating. Sometimes 20 years or so, as well as a long history of frequent and unsuccessful dieting attempts. And I would argue this is because many people don't know they had an eating disorder, or they've been seeing someone who just never picked it up. As I will get to in a moment, they're often in larger bodies. So they're unfortunately, as we will talk about, there's a lot of stigma with being in a larger body. And so they're dismissed, and they're, oh, you're just lazy, you don't know how to eat, instead of exploring whether this person may have an eating disorder. And as I just imply, binge eating disorder often co-occurs with obesity or high body weight, but it's very distinct from individuals compared to individuals with high body weight, matched on high body weight. Those with binge eating disorder have greater caloric consumption, more unstructured eating, and greater eating disorder pathology. So they have much more concerns about their eating. They think about food more. Their over evaluation of body shape and weight is similar to that of individuals with bulimia nervosa. They also have elevated rates of psychiatric comorbidities compared to individuals with uncomplicated high weight or obesity. And finally, there are data showing that they have more impairment overall and lower quality of life. And furthermore, there are some data showing that they have more health problems such as type 2 diabetes, but those data are less definitive. So I will happily pass this over to my colleague, Dr. Lavender. Thank you.
All right, thanks very much. So I'm going to continue and conclude with our sort of intro to the major eating disorders. So the next disorder that I'm going to just give you a brief overview of is sort of one of the newest feeding and eating disorders, at least as identified within the DSM, the current DSM framework, and that's our avoidant restrictive food intake disorder, or ARFID for short. And ARFID is characterized by a persistent failure to meet appropriate nutritional or energy needs as sort of defined by one of a number of possibilities. And those possibilities include significant weight loss, significant nutritional deficiencies, dependence on a feeding tube or oral nutritional supplements, and marked interference with psychosocial functioning. Some of that description to many of you may sound similar to anorexia nervosa, and you would not be wrong in the similar sounding features of that first criterion. One of the most important criteria that separates ARFID from anorexia nervosa or other eating disorders is that within ARFID, there is no disturbance in the experience of body weight and shape. And ARFID is not exclusively concurrent with anorexia or bulimia nervosa. So it's really the absence of those extreme body weight and shape concerns and disturbances that we see in anorexia and bulimia nervosa that distinguishes ARFID from those disorders. Importantly, this sort of failure to meet these appropriate nutritional and energy needs cannot be explained by a lack of food availability, such as in the context of food insecurity or other socioeconomic or cultural features that may limit food intake. And it's not attributable to a concurrent medical condition or other mental disorder similar to most other psychiatric disorders. Really, because this is sort of a newer defined disorder, the research literature is a little bit more limited compared to anorexia, bulimia, and binge eating disorder, but it is a rapidly expanding field. And some of the early research has sort of identified the possibility of there being several subtypes of ARFID. And some of these subtypes look like low appetite and a lack of interest in eating. Those who have a sort of extreme sensory sensitivity, sort of the picky eaters, but on a really extreme degree. And those who have food avoidance or sort of fear of aversive consequences, like fear of pain, nausea, or choking when eating. And just a note about ARFID, in terms of the demographics, another way that it does distinguish itself a little bit from some of the other disorders is that it may be more common in boys compared to the gender ratios in other eating disorders. It often onsets earlier, particularly in childhood, although this can occur and onset in adolescence and even in adulthood, particularly young adulthood, and there may be a longer course of illness. So just want to finish off this section by talking about what arguably many of you would probably end up diagnosing most of your patients with, if you see those with eating disorders, because oftentimes those who are struggling with an eating disorder do not fall into the exact criteria corresponding to any of the eating disorders we just spoke of. And so this would be the other specified feeding or eating disorder category, within which there are several sort of specific examples. So one of these is, and I will mention it first because of its importance and relevance, I think, particularly given the focus of this talk, is what's called atypical anorexia nervosa, although the label of atypical is sort of problematic in a lot of ways, particularly when you talk to individuals who struggle with this condition. But the idea is that this form of OSFED, or other specified feeding or eating disorder, involves an individual who has all of the criteria for anorexia nervosa, but they are not underweight despite having experienced significant weight loss. So this might be an individual who, for example, has severe body image disturbances, has extreme fear of weight gain, has extreme weight loss, and perhaps nutritional disturbances and reduced energy intake. But despite all of that, they are still above what is defined as underweight. One of the important things to remember about atypical anorexia nervosa is that despite not being underweight, these individuals may still experience extreme, severe medical complications associated with malnutrition and malnourishment, despite whatever their current weight may be. And I mentioned its relevance to this talk because there is some recent research coming out showing that atypical anorexia nervosa in veteran populations may be one of, if not perhaps the most common specific eating disorder within those populations. So this may be something that's especially important to look for and to recognize regardless of the presence of low weight status. Just a few of the others that sort of fall into this OSFED category are cases in which all of the criteria are met for bulimia nervosa or for binge eating disorder, except the frequency of behaviors doesn't quite meet that once a week for 3-month criterion. So it could be lower frequency, or it could be lower duration. Purging disorder, which is a disorder characterized by recurrent purging behavior focused on weight and shape, but in the absence of regular binge eating. So it's sort of the flip of binge eating disorder in that way. And then night eating syndrome, which is a form of basically recurrently eating at night after awakening from sleep or in excess after the evening meal. The final area that I wanted to touch on, just because this is an area that is of particular interest to me, both clinically and research-wise, is disordered eating that is focused not on weight loss or becoming or sort of pursuing the thin ideal, which is what most of the eating disorder field was based on. That's sort of the prototype that we see the field coming from. So this alternative is the idea of disordered eating that's focused on muscularity and leanness. This is particularly relevant for men because the body image ideal for men, particularly in Western societies, is this muscular and lean or low body fat ideal. But this is also relevant to individuals pursuing a female body ideal because the female body ideal over time has become more lean and less focused just on thinness. So what we see is that the disordered eating behaviors that are that may manifest in pursuit of muscularity and leanness may look a little different. And these include things like the overconsumption or extreme focus on protein consumption, given the idea that high quantities of protein are necessary to build muscle. Extreme dietary restriction, particularly of certain types of macronutrients, and particularly at certain times, such as reducing carbohydrates. Related to that, the idea of this sort of cyclical bulking and cutting type of cycle in which an individual is over-consuming calories in order to build muscle and bulk, and then cutting, meaning reducing calories and particular types of macronutrients in order to reduce body fat and become more lean and to make the muscles more prominently displayed. Other things that may manifest are things like needing continual access to food and particular types of foods, eating for functionality, eating beyond feeling full, which can sometimes also look like binge eating, and the idea of really extreme cheat meals or full days, and also importantly, the use and sometimes the illicit use of appearance and performance enhancing drugs, ranging anywhere from legal substances like creatine to pre-workout or one of the countless supplements that are available, all the way up to illicit substances such as anabolic steroids. And then I just wanted to put a quick note in about the idea of muscle dysmorphia, which is technically a type of body dysmorphic disorder, but it can overlap with eating disorders and is basically characterized by an extreme focus on musculature in a way that an individual feels as if they are not large or muscular enough, despite being quite muscular already, and can be associated with not just extreme body image distress, but many disordered eating behaviors. So from there, we're going to go ahead and shift. Now that we've given you an outline of eating disorders and what disordered eating looks like, we're going to step into talking about how do you assess for disordered eating or for eating disorders with individuals who may present with issues in that domain. So I wanted to just note a few quick sort of challenges related to the assessment of eating disorders, some of which are consistent with any assessment of psychopathology and others that are a little more challenging with eating disorders specifically. First are limitations of self-report. So just talking to an individual, even if they're treatment seeking, there are things like recall and other related biases that can impact their memory of certain behaviors, the timing of them, the frequency of them, et cetera. Individuals who have limited eating disorder or mental health literacy may not identify with or sort of understand certain symptoms. This may be particularly an issue for men, but certainly can be an issue for individuals of any gender. Minimization of symptoms can occur, and this may occur, again, even in someone who's treatment seeking due to sort of shame and stigma associated with eating disorders. And for those who are in a malnourished or malnutrition state, there can be cognitive effects that affect memory and other things that may impair self-reporting of symptoms. There's also some complicated diagnostic concepts, like the idea of loss of control, which may seem clear to some, but may seem less clear to others. This concept of overvaluation of body shape and weight can be difficult for some to sort of wrap their head around. And so these can be a little bit challenging for the clinician to sort of communicate to patients and to really get the patient to understand these concepts in a way that they can report on them effectively in assessments. So what I wanted to do was basically talk about, in a very general sense, if you want to do a clinical assessment with someone that you suspect has an eating disorder, what are the major topics that you want to address in order to understand what type of eating disorder they may have, what is the breadth and depth of their disordered eating, and perhaps what are some of the factors that may be contributing to that eating disorder. So some of the broad topics to address first, sort of at a higher level, are the history of their eating patterns. That includes things like dieting in the past, their history of body image concerns, how long they've been going on, when they began, things of that nature, and any significant life events that may have contributed to the development of disordered eating patterns. Another important factor is weight history, and that includes, throughout their life, generally speaking, from childhood upwards if they're an adult, and particularly understanding if there has been significant weight loss in the past or recent. Have they had previous treatment for an eating disorder or any other forms of psychopathology? As you heard in the description of the specific disorders, it is very common for individuals who have an eating disorder to have some form of comorbid psychopathology, very commonly mood or anxiety disorders, but others are also possible. And then, of course, what is their presenting problem or their reason for seeking treatment? Are they there specifically because they have self-identified a potential eating disorder, or are they coming in for another reason, but perhaps an eating disorder may also be present? Moving on to more specific information to collect would be to understand eating disorder behaviors. And to do that, it's often helpful to contextualize their full patterns of eating, not just disordered eating ones, but what sort of a daily pattern of eating looks like for the individual. So, what do they eat for breakfast? If they do eat breakfast, do they have a snack, their lunch, their dinner, et cetera? So sort of understanding what eating looks like for that individual on a standard day. The next behaviors to assess would be binge eating and loss of control, which you heard defined earlier by Dr. Chernofsky-Kraft. And these can be complicated to really get a clear assessment of. So as you heard earlier, there is a DSM-5 sort of standard definition for binge eating, for objective binge eating, which requires this consuming an objectively large or definitely larger amount of food than would be normal for the circumstances. So it's important to take into account other factors related to those circumstances. So was it a holiday like Thanksgiving? Was it a special event? What is the individual's age? Are they an adolescent? Are they a full-grown adult? Are there cultural practices that are related to their eating patterns? So really trying to contextualize the amount of food that's eaten in a given episode before automatically defining it as definitely larger. And then for loss of control, some example questions, and these are drawn from the eating disorder examination interview, which is one of the most widely used research interviews for eating disorders, are things like, did you have a sense of loss of control at the time that you were eating? Did you feel like you could have stopped eating once you'd started? Did you feel like you could have prevented that eating episode from starting? So it can often take a number of different questions, a number of different ways of communicating this idea of loss of control with an individual to help them understand sort of what that really means and how they may have experienced it, because loss of control may look a little bit different from person to person. As Dr. Tanofsky-Kraft mentioned earlier, there is a fair bit of evidence that this loss of control feature may be the more, if not only, sort of important feature of a pathological binge eating episode, particularly when you're talking about psychopathology and other correlates related to binge eating. So moving on from the binge eating and loss of control, then there are a number of other eating behaviors to assess for. These include things like restrictive eating patterns, which again can take many forms. It could be simple caloric restriction, it could be food types, it could be macronutrients. And then similarly for purging behaviors, there's many forms from self-induced vomiting, use of diet pills, laxatives, diuretics. Similarly, and increasingly common may be the use of other appearance or performance enhancing substances that may be like muscle building substances or fat burning pills or substances of that nature. Certainly excessive or compulsive exercise, which in and of itself can be difficult to assess. It's beyond the scope of today, but really it seems like much of the pathological aspects of exercise, at least within eating disorders, sort of is characterized by the compulsive nature of the exercise, perhaps more so even than the amount of exercise. And then other behaviors that involve checking body weight or shape, which can include weighing behaviors, as well as things like touching the body, pinching the body, checking for size of body parts. All right, so moving from behaviors now, thinking about assessing thoughts and attitudes. So some of the basic ones to begin with are getting an understanding of the individual's perception of their body size, assessing for fear of weight gain and fear of being fat. This is also, again, sort of a complicated construct depending on the individual's body size. And we'll talk about, Dr. Chevet in particular, we'll talk about weight stigma later, but the aspect of weight stigma can come into play here and can really complicate sort of this understanding of what fear of weight gain or fear of being fat is for individuals who are living in larger bodies. There's also food rules, so very strict classifications of good, bad, forbidden foods, the timing of eating, which is increasingly prominent now because of the increased popularity of things like intermittent fasting. And then, of course, that perceived importance of body shape and weight, particularly in relation to other aspects of an individual's sort of self-identity. And then moving beyond just the symptoms is what is the sort of impact of those symptoms and what is the experience of those symptoms like? And this is getting into things like how much time does the individual think about eating? How much time do they take to plan? How much time are they preoccupied? Some individuals with eating disorders find themselves so preoccupied, so distracted by thoughts of food or eating that it is sort of a constant distraction from their other daily life activities. Is it impairing psychosocial functioning? Are they, avoiding hanging out with friends for fear of being put in a situation where they have to eat in front of others? Are they, missing work because they don't want to go to an event where food is going to be around? This can manifest in a number of different ways. Certainly any of the comorbid psychopathology symptoms that we spoke about previously. And one that is, again, increasingly recognized, but very important to consider is the presence of food insecurity. And there's evidence that individuals who have higher levels of food insecurity may be at risk for certain symptoms, such as binge eating, which may seem counterintuitive, but it is still important to assess within the context of an eating disorder assessment, even if the individual is engaging in binge eating behavior which may seem sort of counterintuitive for a relationship with food insecurity. And then some other related, oops, was that me or someone else? The slides just went away on my side.
Yeah, stand by for one moment. We'll get
Okay.
them back up. Sorry about that.
Not a problem.
While we're waiting, we could actually hit one of the questions if that's okay. If that works for you. There was
Sure.
a clarification question. We'll save some of the others for the end, but somebody asked if voluntary fasting as protest fell under that category of ARFID. And I think that's a quick one to answer.
I mean, it's a great question. I would, without more detail, it's always hard to answer these types of questions. But my immediate reaction is that no, because again, sort of the idea of ARFID is that these things are being driven by factors, and there's lots of different theorized factors, but it's not necessarily a voluntary behavior. So I think voluntary fasting is, in this context, as a form of protest, would likely not necessarily, be a form of disordered eating, unless there are a lot of other things. So for example, an individual who has an eating disorder could also engage in voluntary fasting as a form of protest. This comes up in a different form, but for example, fasting for religious practices can sometimes be a challenge for individuals who struggle with disordered eating. So you just really want to understand, is this happening completely independent of any other eating disorder symptoms, behaviors, thoughts, attitudes, etc.? If so, it's likely an independent behavior. But if it's also connected to other eating disorder behaviors, then it may warrant more assessment and potential intervention. Okay, so I'm going to go ahead and jump in to finish up the assessment section. So just some other things that, especially sort of in our modern society, to look out for are things like, this is true particularly for adolescents, but increasingly adults, are things like social media and use of apps. And that could include anything from the probably thousands, tens of thousands of calorie counting, fitness, and weight related apps. Obviously, social media can have a very impactful influence on individuals who are at risk. So there's like Thinspo or Thinspiration, Fitspo, Fitspiration, Pro-Ana, Pro-Anorexia, Pro-Mia, that's pro-bulimia websites. And then things like fat talk or weight-based teasing, which can happen both online or in person. So all of those things are factors that may be useful to assess in order to understand how they may be contributing to the risk or maintenance of disordered eating. And then participation in activities that have strict weight control or appearance focus. That can include things like athletics, especially certain sports like wrestling, or any time that there are very strict weight guidelines, but also other things like dance, modeling, and obviously participation or service in the military, which we will hear about more at the end of the talk today. Let's see. So the last point I just wanted to make is that one of the ways that eating disorders is somewhat unique compared to many other forms of psychopathology is that because the eating patterns are disturbed, they can have significant medical and physiological consequences, which you heard about earlier. And as a result, eating disorders often require multidisciplinary treatment, and certainly multidisciplinary evaluation is usually recommended. And depending on the severity and the nature of the eating disorder, may necessitate a higher level of care or a level of care higher than standard outpatient. So an evaluation will often include both a medical exam and labs to evaluate for physical health. And I want to note that this is important. It does not matter the individual's current weight because they could have a typical anorexia nervosa and be suffering consequences from significant weight loss. They may have bulimia nervosa, and individuals with that disorder are often in the quote unquote normal weight range, but may have significant electrolyte imbalances or other issues. So it's important to remember, I'll just reiterate, that individuals of any body weight and shape and size can have an eating disorder. So it's important to evaluate these individuals in a similar fashion and not rule out things just because of their body size. Individuals may often participate in a psychiatry or a medication consultation. Many individuals with eating disorders who are participating in psychotherapy, for example, may also be taking a psychopharmaceutical medication. And then nutritional and dietary evaluation by a registered dietitian can also be very useful. One thing that's important is that because many registered dietitians are sort of trained more to focus on weight loss, it's very important that when an individual with a suspected eating disorder is working with a registered dietitian, that individual have knowledge about and experience with patients with eating disorders so as to not accidentally exacerbate any symptoms. All right, so just a few quick comments on some questions, and I'll speak about this, and then the information on the specific questionnaires I won't spend as much time on because you all have these slides. But in terms of assessing eating disorders, I just wanted to take a few minutes to talk about when you're picking a way to assess. If you're going to use some questionnaires, then you want to take into account a few factors. You want to think about what is the purpose? Is it, screening for a specific diagnosis? Is it understanding the severity of symptoms? You want to understand the suitability of the questionnaire for a given individual. For example, is the language appropriate for that individual's age? Is it freely available or something that you're supposed to purchase, particularly in real world practice? That's a significant issue. And how easy is it to score and interpret? Obviously, measures that are more complicated mean more time spent, and so it's just important to take that into account. So I've put here just a few screening questionnaires rather than going into detail about all of them. What I'll just note is that these are, the first two are really sort of primary care types of screening questionnaires that are just a few items that are very quick. They have variable, efficacy in identifying individuals with eating disorders, but particularly in primary care settings, it's better than nothing. And these are questionnaires that are identified, again, for those primary care settings as the one sort of to use when possible. The last one, the Eating Disorder Diagnostic Scale, is a longer questionnaire and is actually a screening questionnaire that's you can derive probable DSM-5 eating disorder diagnoses from, so it has a little more specificity, and the links to access these measures are below. For symptom questionnaires, if you want to get a sense of the nature, the type, the frequency, and the severity of symptoms, probably the most widely used and freely available questionnaire is the Eating Disorder Examination Questionnaire, which focuses on behaviors and attitudes in the past 4 weeks or 28 days. And you get frequencies of binge eating and compensatory behaviors from this measure, as well as an overall score indicating the severity of eating disorder symptoms, for which there are norms and cutoff scores available for interpreting severity. Sort of a companion measure that assesses psychosocial impairment associated with eating disorders is the clinical impairment assessment. Again, there is a clinical cutoff there, and the measures are available at the link at the bottom of this slide. All right, so I'm going to go ahead and stop the assessment, shift, talk a little bit about the overview for these evidence-based treatments before I pass this back along to one of my colleagues. So matching with what I spoke about regarding the multidisciplinary nature of eating disorders, in addition to multidisciplinary evaluations, a team approach is often going to be necessary in the treatment of individuals who have eating disorders. And this may include psychological or behavioral therapy and nutritional counseling, along with medical and psychiatric monitoring. One of the important features or factors to remember is that for patients who are underweight, such as those who have anorexia or nervosa, weight restoration is always going to be the first and most essential goal, not only because of the life-threatening nature of being underweight for many individuals, but also because there's evidence that getting individuals into a weight restored state will help improve the efficacy of the other intervention components that are being delivered. So thinking about these components, and this is, again, just a very, very quick overview. With regard to psychotherapy, individuals with eating disorders may participate in either individual therapy or group therapy. Some of the common forms are cognitive behavioral therapy, interpersonal therapy, two of which we'll speak about momentarily, as well as dialectical behavior therapy. And then they also may engage in family-based therapy, and family-based therapy actually has the strongest evidence-based treatment for anorexia nervosa in youth. So we'll hear about that more in a moment. The targets are going to vary pretty widely depending on the specific type of psychotherapy and, of course, the patient's symptoms. Restoring weight, again, will always be the first target for low weight individuals, but certainly normalizing eating patterns will be a common feature, reducing restraint and restriction that prompts binge eating, working on interpersonal relationships or cognitive symptoms like weight shape over evaluation, engaging parents as a way to reestablish healthy eating in youth, and improving things like coping and emotion regulation. Also, one of those major components we spoke about was nutrition and dietary education and counseling. And this will typically involve working with a registered dietitian, again, one who has experience and understanding of the unique aspects of eating disorders in order to address knowledge and understanding of nutrition, metabolism, et cetera. The individual or the dietitian may also assist with meal planning and related skills that many individuals with eating disorders may struggle with, including things like shopping and food preparation. And then again, very commonly, particularly due to the comorbid symptomatology that often accompanies eating disorders, individuals may be taking psychotherapeutic medications. Some of those may be targeting symptoms of the actual eating disorder, although oftentimes the medications, as I said, are used to treat co-occurring mood, anxiety, or behavioral control symptoms, things of that nature that commonly co-occur with individuals who have eating disorders. And then finally, medical management will be something that will be important, and the intensity of this will vary depending on the individual's severity of symptoms, type of symptoms, et cetera. And then lastly, just to note, sort of, this is just a quick overview of the levels of care associated with eating disorder treatment. So for example, the lowest level of care would be standard outpatient, which may look like, you know, a session every week or session every other week. Rising up the chart, we have intensive outpatient, which would be more frequently, partial hospital, which would be at, you know, most weekdays for a relatively long period of the day, if not the entire day. Then residential programs, which are 24-hour-a-day treatment, but at a residential setting. And then for the most severe, acute, and medically compromised patients, would be inpatient hospitalization. Oftentimes what you see is that for patients who do require that highest level, oftentimes care over time will involve sort of a step down across these different levels of care once leaving inpatient. For example, an individual might participate in partial hospital or IOP as they transition back out of the hospitalized setting. And with that, I'm going to turn it over to my colleague, Dr. Chabet.
Great. Thank you so much, Dr. Lavender. So Dr. Lavender briefly alluded to family-based treatment, and I just wanted to do a little bit of a deeper dive into what that looks like. So that is primarily appropriate for adolescents or children. It can, however, be applied with young adults, but really the caveat is that they should be living at home. It's really a sort of a foundational part of the treatment is that they are addressing the home environment. It's used centrally for treating anorexia nervosa, but may also be used for bulimia nervosa. And as Dr. Lavender mentioned, this is really the most well-researched and empirically supported psychological treatment for anorexia nervosa in youth and younger adolescents. Importantly, the framework of family-based treatment really takes what's known as an agnostic view of the illness. So the clinician does not come in and say that the family members are to blame, or mom said X, Y, and Z, and that is what initially exacerbated the disordered eating or promoted the eating disorder. So really, neither parents nor the child or adolescent are viewed as to blame for the development of the eating disorder. This is most appropriate for children and adolescents, as I mentioned, with eating disorders who are medically stable. So to the chart that Dr. Lavender just showed, if they are not medically stable, that would indicate that they would be needing a higher level of care. So this might be an individual who has stepped down from a residential treatment potentially, and again, living at home with the family. Importantly, the family must be able and willing to put significant time commitment into the treatment. The family is eating regular meals together. They are processing these meal times with the clinician. And parents are really viewed as not only a part of the solution, but really a central component of the treatment and of the solution, and largely empowered to feel responsible for helping the child to gain weight. The therapist's stance in family-based treatment is really one of deference to the parents in supporting the adolescent. So the clinician will view themselves as they're an observer, they're a coach, they can help kind of problem solve, provide some skills and some tools, but really their philosophy is standing back and letting the family kind of integrate some of the therapy into these family meals, these conversations. And again, really kind of de-emphasizing the cause of the eating disorder. So one of the sort of analogies that a clinician might give is if a child is diagnosed with a form of cancer, the first question is how to treat this cancer. The question is not what caused it, what certain precipitants made this child more vulnerable to that cancer. It would really be a focus on the here and now. How do we help the child to get better? So that's the approach that's largely adopted within family-based treatments. Switching over to cognitive behavioral therapy, this is generally, I think, a pretty widely known therapy. There are very many different types of CBT. I'll be talking specifically about CBTE, which is cognitive behavioral therapy enhanced. And importantly, this is a transdiagnostic eating disorder treatment. So this is really designed to target a number of different disordered eating presentations across adults and adolescents. It's the leading evidence-based treatment, again, for adults and adolescents. It comes in sort of two varieties. One is the focused version, which is the core treatment, or a broader version. And that takes into account some of these other correlates that we've talked about. So distress intolerance or perfectionism, low self-esteem, body image dissatisfaction, and some of those interpersonal difficulties. There are two intensities that the clinician can choose. One would be more intense, and that would be used in the case where an individual's BMI is placing them in an underweight range. So that would comprise more sessions versus a 20-session program that would be better suited for individuals whose body weight put them in more of a normal weight category. Relatedly, there's also a CBT guided self-help module, and that is less intensive than the CBTE that I mentioned that is really driven by the clinician. This is really a self-help program that is guided by a healthcare provider. So the clinician would serve as sort of a facilitator and guide, and the patient or client themselves would be following along through this manual with support from the clinician. And that's really targeting the binge spectrum type disorders. This would not be appropriate for anorexia nervosa, which would necessitate a more involved therapy. Some of the core stages of CBTE, it begins with the phase called starting well. That's really focused on getting the patient engaged, starting to establish regular meal times, starting to address some of those core features like body image dissatisfaction or binge restraint cycles. The next stage would be taking stock. So that would be starting to review progress, identifying what are some of the barriers. Maybe part of you wants to change, maybe part of you doesn't. How can we take stock of your progress and your investment in the program? Stage 3 is addressing setbacks. So that's really where the clinician would focus on what are some of the mechanisms and factors that are maintaining this disorder, and how can we address the inevitable relapses or challenges that might come about. And then the final stage is known as ending well. So this is really where the emphasis is placed on maintaining that progress and those changes made over the course of therapy, and also to help minimize the risk of relapse or problem solving. What can the client do if they are faced with relapse, or a particularly stressful situation that they are anticipating might cause them to relapse into some of those behaviors. Some of the core elements of CBTE include a personalized transdiagnostic formulation. So the clinician really working closely with the client to understand better what is driving this disorder, what is maintaining it, what are some of those unique factors. It also includes psychoeducation and self-monitoring. So monitoring intake or mood, what you're eating and when, and really trying to establish a regular pattern of eating. What we see in a lot of patients with eating disorders is that their eating can be very, very erratic and sort of alternating between sort of periods of feast and periods of famine. So we want to kind of establish a more regular pattern of ideally 3 meals, 2 snacks a day, depending on the client. It often incorporates in-session weighing. I think that is one that we might defer to clinician judgment and their determination of whether that might cause more harm to a particular client. So that might be subject to the client's determination or the clinician's judgment. Incorporating significant others. So how can we optimize this individual's support network and sort of harness the power of their social supports, whether that's a romantic partner, family, friends, coworkers, et cetera. And then dealing with those inevitable setbacks and maintaining change. So we really encourage clients to not view this as a perfectly linear course of treatment. There will be ebbs and flows, and there will inevitably be setbacks. How can we address those as minor relapses and not sort of a collapse? Okay, moving along to interpersonal psychotherapy. So the rationale for this form of psychotherapy is that eating disorders do not develop within a vacuum or in isolation. They develop within a specific social and interpersonal context, and that the relationships between the individual and their significant others impact both the maintenance of the disorder as well as their response to treatment. So the focus of this form of therapy would really be on identifying and modifying one's interpersonal context in which that eating problem has been developed and maintained over time. At the outset of therapy, the clinician would link the onset of the eating disorder to one or more of the following what they're known as problem areas. So those might include grief, such as the death or loss of a loved one. That could also be something like a breakup. Would qualify as well. A role dispute. So for example, non-reciprocal expectations in relationships. We might see a lot of that with our adolescent clients, and they're sort of navigating these difficult interactions with parents or with peers. Role transition, so difficulty coping with life changes. You can imagine how that might come into play, particularly when treating members of the military family as well, things like deployments or changes of station and so on. And then also interpersonal deficits would be the fourth area. So that might be an individual who is coming to therapy with a history of inadequate, unsatisfying relationships. And as the clinician, you can really target what's going on here. What's driving this? Is it ineffective communication? Is it unrealistic expectations? What is sort of driving this consistent pattern of inadequate or unfulfilling relationships? So I will hand it off here to Dr. Tanofsky-Kraft to begin our discussion of military relevant considerations.
Thank you so much, Dr. Chevet. So research suggests, and many of you have probably heard this, that eating disorder prevalence may be higher in service members compared to civilians. Now, the data aren't great, so I say this tentatively, and it's a suggestion, and that's because what we end up doing is we end up having to compare published studies of military samples to published studies of civilian samples. So to my knowledge, there is no clear-cut comparison of the eating disorders comparing civilians and service members. But as you can see, and this slide shows women on the left and men on the right, generally speaking, individuals in the military in the darker purple bar have higher rates, particularly of bulimia nervosa and binge eating than do civilians. Although the data and the data are likewise with men, and there's some data to suggest that this discrepancy is even larger among men than women in uniform. So what do we know about the prevalence of eating disorders? Well, we do know that it varies across services. The rates are estimated to be high. Maybe 10% of individuals in the service are struggling with an eating disorder. And if that pans out as we continue to do more research, that's about 3 times higher than civilian groups. Data suggests that maybe 3% of service members have bulimia nervosa, 7% have bulimia nervosa, 50% or more engage either in binge eating or have binge eating disorder. Again, the data aren't great. They're generally old, but we're trying to rectify that by doing science right now. As I mentioned, male service members may be at equal or even greater risk of eating disorders than female service members, and that's really a standout, because if you think about it, despite what Dr. Lavender shared, and that we know that eating disorders are more and more being identified in men, the literature largely seems to focus on the fact that eating disorders are among females. What's important is that these data are likely underestimates, these percentages. But as I said, we're hoping to rectify that in the coming years as more data becomes available. So it's also estimated, and this is really interesting, and I think it speaks to what Christian maybe brought up in the chat, and that is that an estimated 1 in 3 service members engage in something that's been coined situational eating disorders. And that has been defined as abnormal eating behaviors consistent with the disorder, practiced intermittently and in response to external pressures associated with significant distress. And most commonly, that is military weigh-ins or physical fitness testing. We see this in potentially 30% of individuals. Again, this is research that is desperately needed. There are also data to suggest that untreated, this situational eating disorder, or disordered eating surrounding fitness tests, are likely to develop into one of the full syndrome eating disorders that we have already discussed. So what are the risk factors for eating disorders in service members? So there's access to high calorie food. If you go on any military base, for example, we're sitting here on Walter Reed's base, and there is just tons of restaurants, fast food places, lots of junk food. There's limited time, so that's where people often turn to when they are short on time and they need to grab something to eat. In terms of deployment, there are MREs, or meals ready to eat, which many of you may know this, but they're prepackaged energy dense meals. They were designed for a time when people would be very, very physically active and needed that in density of food to keep them going. We don't, many jobs in the military now are not that active. So these types of energy dense meals may also be problematic, as well as sort of engaging in eating unhealthful foods that can impair the metabolism that might lead to binge eating. We know that combat, especially for women, has been linked to the development of a new eating disorder. It's a stressful career. People worry about their safety. There's often relocation. It's a high intensity job serving in the military. And we know that stress is robustly linked to eating disorders. So, risk factors for eating disorders, specifically the body composition and fitness standards. Of course, there's this pressure to make weight. There's a desire to be fit and muscular. And one of the interesting things is that many people who join the military have been prior athletes. And because they may have more muscle mass, they end up weighing more, and they may not, their body mass index appears to be too high to make weight, yet these are some of the strongest people and arguably some of the most effective people serving. So that's a problem. And finally, there's this need to achieve and maintain military appearance, or looking very much like they look like they're in the military. And I see Christians making a comment here that taping is very embarrassing. I don't have time today to talk about, but I've heard numerous stories of individuals who have who've had really embarrassing, uncomfortable, horrible stories about not making weight or meeting their fitness standards and how they're treated. So there's also concerns about standards associated with body dissatisfaction and unhealthy weight control behaviors. We talked about that a little bit, about engaging in these associated with the standards. And, for example, do fasting, being in saunas, wearing, sweatsuits, things like that, to do anything you can to make weight. And there is some research to suggest that standards may also exacerbate pre-existing disordered eating. And this is really problematic because there are high rates of disordered eating prior to joining the military. So with that said, I am going to pass this back over to Dr. Chevet.
Great, thank you so much. So for the next couple of slides, I wanted to address something known as weight stigma, which I think is a term that more and more people are becoming familiar with, but basically the experience of mistreatment, derogation, or discrimination due to one's body size. So we conducted a study a few years ago to ask about experiences of weight-based stigma within the military, and we found, perhaps unsurprisingly, that just about half of the sample of individuals, and these were individuals who were presenting for an obesity prevention program, but about half of them reported that they had experienced at least one instance of weight-based stigma within the military. And what did those experiences look like? It really ran the gamut, but some of the most frequently reported experiences were things like receiving disciplinary action as a result of one's body shape or weight, coworkers or friends asking intrusive questions or personal questions about one's weight, being passed up for a promotion or award due primarily or exclusively to weight or physical appearance, and also being told that one's weight or shape didn't meet those military standards that Dr. Chinovsky-Kraft was alluding to. So as I think we're all aware, each service does have its own standards, and the ability to meet some of those standards do impact one's military career in significant ways. So repeatedly failing one's fitness tests or body composition assessments could lead to separation, and those opportunities for additional training, promotions, and the ability to deploy or re-enlist are determined in large part by meeting those standards. I want to transition just briefly to veterans before I hand it back over to Dr. Tanofsky-Kraft to address the rest of the military family. But similar to their active duty counterparts, veterans may also be at greater risk for eating disorders compared with non-veterans. Unfortunately, eating disorders are not routinely screened for in VHA settings. And as a result, estimates vary widely depending on the methodologies used. So as you might expect, if we use just electronic medical records that are relying on a diagnosis of an eating disorder, the rates are much lower. However, if we turn to some of those questionnaires that Dr. Lavender mentioned earlier, the rates are much, much higher. Also, methodologies like in-person or telephone interviews typically yield higher prevalence of eating disorders. Some of the reasons contributing to those additional risks observed in veterans include things like trauma exposure, military sexual trauma, some of those poor eating habits developed during time in service that were adaptive during one's time in service, that rapid or marked decrease in physical activity immediately post-separation, as well as some of those entrenched disordered eating attitudes and behaviors that take years and years to develop. So not surprisingly, they may take years and years to sort of uncouple and disentangle. So I will pass it back to Dr. Tanofsky-Kraft to address some of the other members of the military family.
Thank you so much, Dr. Chabet. This is an area that's been near and dear to my heart and a focus of my own research for some time. So we have been studying and trying to understand adolescent military dependence. And in a study that actually was headed up by Dr. Chabet several years ago, we did what I thought was a really nice study because we were able to age, weight, sex match civilian adolescent dependents and the adolescent children of military service members. And as you can see, we actually see that these adolescent dependents not only have more disordered eating attitudes over concern about shape and weight, but also they report significantly more binge eating episodes than their civilian counterparts. And not shown on this slide, we also see they have more depressive symptoms, as well as are more likely to have insulin resistance. So there's a number of factors that are concerning for the children of service members. What's more, and sort of parallels the adult research, is that adolescent dependent boys may have similar or higher rates of disordered eating than their female adolescent military dependent girls. So you can see they have similar levels of disordered eating attitudes and actually report significantly more binge eating episodes. And this is really important because it affects not only the health of these children and families, but pipeline for recruitment, because we know that about 77 to 86% of new recruits have had a family member who served. So we might be potentially, sending individuals who could be, who are more likely to have an eating disorder into the service. So what are some of the risks of eating disorders among the military family? Well, there are a number of stressors. First of all, they're exposed to their parents' focus on weight and appearance. They're often at home with one parent when another parent deploys, or with a different caretaker, so they'll have to adapt to different caretakers. They may have added responsibilities when one or more parent is deployed, and concerns about their safety. Those are important stressors. There's also the stressors, which are very intense for adolescents and children, new social environments. So they are often moving schools, and so they may be getting lack of consistent, not only educational support, but other, social support. And again, they are exposed to their parents' potential extreme dieting behaviors or weight control behaviors to make weight, and their parents' over concern about appearance. And as I referred to before, this all has an impact on military recruitment and retention and readiness. First of all, individuals who have had an eating disorder for more than 3 years after age 13 may be disqualified from even joining the military. Even if they do join the military, we know that there are significant health problems and emotional problems linked to eating disorders. So that is very likely to impact military readiness. And finally, it can limit one's promotion and lead to separation or discharge, which impacts retention. So with that, I will pass back to Dr. Chevet.
Great, thank you. And I do realize that we're just about out of time, so I will breeze through these last couple of slides. And then I think Dr. Ermold and I were communicating over the chat that we are happy to provide some written responses to all of these fantastic questions and distribute those. So with that being said, I wanted to just wrap up with some clinical recommendations. And some of these are things that you can kind of take with you today and start to implement in your own clinical practice or research setting or your own personal life as well. So we really encourage everyone to adopt what we refer to as a weight inclusive approach, wherein the emphasis is on health and health promoting behaviors, irrespective of weight or body size. So how can we do that within our healthcare spaces? Well, first of all, and I know that this seems contradictory to some of the information that we provided above, but asking patients if they would like to know their weight, especially when they're coming in for routine medical care. And somebody had mentioned in the chat, offering to weigh them backwards and not announcing the number if they would like. Placing scales in private areas when feasible, and keeping in mind that many patients may avoid healthcare altogether just to avoid being weighed and the fears of the accompanying lecture that they might receive from their healthcare provider. We also need to ensure that all of our supplies and our equipment can accommodate patients of all body sizes. So things like blood pressure cuffs and patient gowns, exam tables, providing armless chairs in the waiting rooms, and so on. And also ensuring that our scales are adequately sized to accommodate patients of all body sizes. Finally, as I mentioned at the beginning, language matters. We really want to avoid any terminology that might imply shame or blame of our patients. We want to really refrain from making assumptions and recognizing that BMI alone cannot tell us anything about a person's diet, their activity level, or their health status. Again, weight is not an accurate proxy for health in the absence of other markers. We want to ask about current health behaviors and any health-related goals that an individual might have, irrespective of weight. Again, focusing on those health behaviors, not a number on the scale. We also want to emphasize that multifactorial etiology of weight and address weight sensitively with our clients. Address and challenge weight stigma when we see it with our peers, with our colleagues, with other providers, or in academia broadly. And finally, as we've mentioned throughout, really ensuring that you are regularly screening for disordered eating in all patients, irrespective of body weight. We know that so many patients are overlooked just by virtue of their size or weight. So we really want to make sure that we are kind of closing those gaps and ensuring equitable distribution of resources to patients of all body sizes. So I know that we're just at 1:30, and we will compile all of these excellent questions and make sure that we're able to provide some written responses. We also welcome any of you to reach out to us individually as well to continue this conversation.
Well, thank you. I'm going to do a quick thank you, not because I'm trying to short shrift the thank you, but I'm just aware of everyone's time. I think the chat, the interest, the questions all reinforce the interest and importance of this area. And so we're delighted to continue to work with Dr. Chevet, Dr. Danofsky-Kraft, and Dr. Lavender to bring you more content and more answers. So thank you. I'm going to quickly turn things over to Micah, Mr. Norgard, to give us your CE spiel, and we'll close the room pretty quick. So grab that link so that you can get what you need.
All right, thank you everyone for joining today. Once again, I put that link into the chat. If you have not been here before, you're going to click on that link. It's going to take you back to the My Account page where you clicked Launch Webinar. To the right of that will be an orange certificate button. Click on that button. Once you've clicked on that button, it will open up a little pop-up window where you can complete your evaluation and then print off your certificate. If for some reason it says that your seminar is not complete, just wait about 2 hours. We'll be taking attendance from now until then. After 2 hours, if it still says seminar is not complete, go ahead and email me, and yeah, I'll get back to you as soon as possible. Once again, thank you for joining today's webinar.
Thanks so much. Thank you to our speakers, and we hope to see you again next month. Have a fantastic day. We'll be closing the room in like 15 seconds.